Gives me also great pleasure to invite Dr. Maithel, Shishir, again another great friend and a great contributor to the field. Shishir is from Emory. He leads the pancreas and hepatobiliary surgery effort, actually the center over there. Shishir actually is incredibly active in the world of research. As a surgeon, he's a fantastic surgeon from what I hear from a lot of our colleagues at Emory. But at the same time, he leads multiple trials. In fact, he leads multiple chemotherapy trials, and he's trying to transform how we essentially treat our early stage biliary cancer patients from bringing adjuvant therapy actually into the preoperative setting, because we know that a lot of our patients miss on the opportunities and the potential benefit from getting treatment before, also helping facilitate some of our patients to get to surgery. So he's been leading that field. He also is leading another trial that's going to be an international trial, trying to understand a little bit what we do with those gallbladder cancers that are found incidentally. And that's a tremendous effort, really has been one of his trademarks. So without further ado, Dr. Maithel will be talking about trials of neoadjuvant therapy in cholangiocarcinoma.
Thank you. First, good afternoon. First, I'd like to thank Drs. Lewis and Dr. Knox for inviting me to speak today, and also thank you to Stacy for allowing me to be part of this amazing effort. So my task was to talk about trials in neoadjuvant therapy in cholangiocarcinoma. One disclosure, I will talk about Celgene as funding a trial for which I am PI. So quickly, we'll do a little literature review, discuss the feasibility of this, and then I'll kind of break it down from a site-specific way in terms of distal, hilar, and intrahepatic. Now, I will fully admit that you've heard a lot about molecular profiling these last 2 days and 3 days, and really approaching and thinking about cholangiocarcinoma from a simple anatomic, distal, perihilar, and intrahepatic seems a little bit crude. However, again, for neoadjuvant trials, the anatomic and technical considerations of the tumor location and surgery really come into play. So I think it's probably the easiest way to discuss it is to actually do it in a site-specific manner. So when I first got the invitation, I went on PubMed and I went to clinical trials and I typed in neoadjuvant trials for cholangiocarcinoma. And you can see there, search item results, 0. I said, wow, this is going to be the shortest talk I've ever been asked to give. Done. I can just sit down now. But really, I adjust a little bit. So then you take away that, you type in neoadjuvant therapy for cholangiocarcinoma, and you're left with these small studies, one published in 2011 with 12 patients, another one published in 2003 with 7 patients. There just hasn't been a lot of effort towards this in terms of in the neoadjuvant fashion. Majority of what you've heard in the last 2 days is all for patients with metastatic or advanced disease or non-resectable. We've heard a little bit of the adjuvant efforts, but majority of this is really in patients with advanced disease. So why is that? Well, the feasibility of neoadjuvant trials, not only for cholangiocarcinoma, but for any solid organ malignancy is difficult. But if we focus on cholangiocarcinoma, it's a rare cancer. So you need this multi-institution and multinational collaboration. That's really one of the themes and spirits that we're here today, and I think the Cholangiocarcinoma Foundation really is the poster child for in terms of collaboration. The other thing is majority are not resectable. The definition of a neoadjuvant trial is giving therapy prior to resection for patients with resectable disease. This is not downstaging, this is not converting non-resectable to resectable, but this is really pre-treating resectable disease. So if you don't have resectable disease at presentation, you cannot enroll in a neoadjuvant trial. The other thing is preoperative tissue diagnosis. It's difficult for some of the sites. For intrahepatic, it's relatively simple with the liver biopsy. However, for our distal cholangiocarcinoma and for hilar cholangiocarcinoma, they can actually be quite challenging, and we'll go into some details. And the other thing, I didn't put it here on the slide, but I will say is as I've been kind of, thinking about all the presentations and thinking about Melinda's presentation in general, Patients want surgery. You've seen that. You're the patients who responded to that survey that she reported at ASCO GI and said to you today. Patients have 1, 2, 3, 4, 5 surgeries. People want surgery even if it's not curative. If you're told you can't have surgery, 90% of you will want a second opinion, 45% of you want a third opinion. So convincing people that a neoadjuvant trial for patients with resectable disease is not easy. And I think it's very inherent on the trusting relationship between a patient and their physician. And I will go so far as to say it's very inherent on the relationship between a patient and their surgeon. And that really relies and really stands on the intrinsic belief that we do have the patient's best interests at the forefront of our minds and hearts. So I will say that in terms of feasibility, it's challenging. Now, in terms of distal cholangiocarcinoma, we'll take it in a step-by-step fashion. So distal cholangiocarcinoma only represents about a third of the extrahepatic, but if you think about the anatomy, it only represents about 10% of what we call periampullary tumors. Now, it's often kind of lumped in the pancreas cancer bucket because pancreas cancer, by 70%, 75% of the periampullary tumors, has a lot of attention. It's the 4th most common cause of cancer-related deaths in the U.S. and is rising. Now, the reason they get lumped together is because from a technical standpoint, it's the same operation for both, pancreatic duodenectomy or a Whipple procedure, and some of you in the audience have had that. And it's the only curative treatment option for both. And additionally, the treatment algorithms for pancreas cancer have often been extrapolated and applied. So just to kind of briefly review the anatomy, you can see this is where the duodenum kind of cups the head of the pancreas. The bile duct is coming down there, as this is called the intrapancreatic portion of the distal bile duct. And in that red circle is really where the distal cholangios and the pancreas cancers often arise from. And as we have alluded to many times, it's very difficult or almost impossible to accurately or reliably distinguish the two in a preoperative setting. There's no really biopsies that really can differentiate it. There's no IHC stains, and really it's based on the crude gross assessment by the pathologist. The other reason I think distal cholangiocarcinoma has not really received a lot of attention in the pre-op setting is the literature up until recently, I think, has kind of grouped them and has suggested that they are relatively the same disease. If you look at this report from Hopkins, you can see that they're looking at the 4 different types of periampullary cancers, and you can see that the bile duct and the pancreas one, the lines may be split there, but however, if you really kind of look into the details here and you just look at the sites, only 65 distal bile ducts with 445 pancreas cancers in this, and you can see that the P, if you go scroll over to the right, you'll see there's a non-significant p-value of outcome with the distal cholangios compared to pancreas cancer. So when people start reading that in another, you see a study from Ohio State, Tony's old institution, you'll see that the curves between distal cholangio and pancreas are superimposed, again suggesting that maybe they should be treated the same way. However, again, look, cholangiocarcinoma, only 18 patients compared to 250 pancreas cancers. Another study, again, showing the same thing, superimposed lines. So this emphasis on distal cholangio has really kind of been escaped based on the kind of the thought up until recently that they are maybe similar disease. Maybe we should treat them the same. People extrapolate a lot of the same therapeutic strategies of pancreas cancer to distal cholangio. But again, even in this one, you can see only 50 patients. So with a special interest in this, I have been privileged to be part of multiple consortiums and collaborative research groups. I've been blessed to actually have great friends and be able to lead some of these as well. So we started the U.S. Extrahepatic Biliary Consortium a few years ago, some of whom my colleagues are in the audience today. And I'm also honored to be part of something called the Central Pancreas Consortium. So with the strength of these collaborations, we were able to actually collect a large series over about 10, 12 years, and we had 203 distal cholangiocarcinomas and over 1,000 pancreas cancers. And now when you look at those lines and you have these numbers and you actually have maybe a potentially real powered analysis, you can see that they're not the same. And this is just a kind of a snapshot of that, but looking at the effective chemotherapy, types of chemotherapy, they respond differently. So we really need to focus on distal cholangio as a distinct disease. Now, how do you do this in a neoadjuvant? Just yesterday our surgical working group was meeting over lunch and we were talking about this. How can we do this? And as I mentioned, the diagnosis is really based on the gross surgical specimen. There's some hints we have in the preoperative setting in terms of the radiologic imaging. Is there a mass in the pancreas versus not? Is there thickening in the bile duct? Are the brushings positive? Is there absence of pancreas duct dilatation? All of these can kind of hint toward distal cholangio, but I will tell you from experience that even when you think it's distal cholangio, I would say at least 80% of the time on resection, it ends up being a pancreas cancer. So then how do you do trials for distal cholangiocarcinoma when you're going to be contaminated with a lot of pancreas cancer in the specimens? Those are all things that we're still really trying to work out. So I will say those are all still very much under consideration, but again, we're thinking about it. In terms of Hilar, we'll start moving up. We're going down to up, basically. In terms of Hilar cholangiocarcinoma, this is the most frequent site that we'll see. About 6,000 new cases diagnosed annually in the United States, but still very rare. We know these are rare cancers, but it represents about 2/3 of all the cholangiocarcinomas. Primary sclerosing cholangitis, or PSC, is a distinct risk factor for development of it. However, the majority do present with de novo or non-PSC Hilar cholangiocarcinoma. And again, we know surgery is the only potentially curative treatment option. So if we say the standard of care for resectable disease outside of PSC is resection, and we have to understand that the resection for the Hilar cholangiocarcinomas is a pretty involved resection. It involves a major hepatectomy, bile duct resection, a reconstruction with a portal lymphadenectomy, and then a reconstruction to the intrahepatic or just the extrahepatic bile ducts. Only about 1/3 or 40% or so are really amenable to resection. About 2/3 are not resectable at presentation. And even of those that we take to the operating room, a fraction of them, or a good number, even sometimes half, are found to be not resectable at exploration due to vessel involvement or findings of subradiographic metastatic disease. So the resection can be challenging in and of itself. So when doing neoadjuvant therapy trials for patients already with a challenging resection, that can get a little bit challenging. Now, but the needs are there. So let's look at some of the data in terms of resection series. You can look that if you look at over the years, and these are relatively recent series, 2010 and on, that the margin negative, or R0, margin negative rates of resection range as low as 30%. I think those are probably some of the older studies, but mostly somewhere in the 60 to 80%. There's significant morbidity with these operations, 40 to 70%. So you need your patients as strong as possible going into the operation because recovery is difficult. Mortality, our mortality after Whipple operations is less than 3% now, mostly 1 to 2% in high volume centers. For major hepatectomies, our mortality rates are less than 2%. But look at the mortality rates after resection of Hilar cholangiocarcinoma. These are perioperative. It can be anywhere from 1 as high as to 15%. And then in terms of the recurrence, we are doing these as the only curative intent option, and we're doing these with curative intent. However, we can see that 50, 60, 70% of these patients are recurring, and you can see that what that translates to. Recurrence is often difficult to rescue, and 5-year overall survival after resection is in the 30% range. You'll see different, this is from the Italian series, you'll see different numbers in Japan, but I think we'll stay with the Western data for the context of this talk. Now, in terms of the role of neoadjuvant therapy for Hilar cholangio, I think the best example is what you heard yesterday from Dr. Heimbach in terms of the transplant protocols for Hilar cholangiocarcinoma. When you look at transplant for Hilar, it's almost a mind shift. You have to think of the transplant almost as an adjuvant therapy. The chemotherapy and the radiation is so intense that even if you talk to Julie and you talk to Dr. Rosen, some of the other transplant surgeons at the Mayo, it's really the chemotherapy and the radiation that's the treatment, and the transplant's kind of mopping it up, and that's what you could almost consider that the adjuvant treatment. But it's a very intense regimen. It involves, some other institutions have modified this, but really it involves intense chemotherapy, intense radiation, and then they go on to liver transplantation. So what are the challenges with neoadjuvant trials for Hilar cholangiocarcinoma for patients who are going to undergo resection and not transplant? Well, one is getting preoperative tissue diagnosis. For the distal cholangios, we can usually get it from either brushings or an EUS. It's usually not a problem. However, for the Hilar cholangiocarcinomas, this can be a lot more challenging. The brushings are often not diagnostic. Sometimes you have to do spyglass endoscopy, which requires being at an experienced and a very expertise center. Sometimes sending out the specimens for fish analysis. All of these things make the diagnosis very difficult to obtain, which then makes enrolling into a neoadjuvant trial, and for medical oncologists and radiation oncologists being willing to deliver chemotherapy and radiation outside of a tissue diagnosis. The other thing is cholangitis. Often, given the level of obstruction, dealing with the level of obstruction with multiple or sometimes one or two percutaneous biliary catheters is much difficult compared to just a single stent in the distal bile duct. And then giving therapy to patients who have on and off episodes of cholangitis is very difficult. Third is the use of radiation. In transplant, they do extremely high doses of radiation, but when they do the transplant, the entire biliary apparatus is removed. In resection, we have to keep that biliary apparatus and sew to it. And sewing to that bile duct after it's been radiated in that setting is not something we like to do. I think the risks of stricture and leaks are extremely high. So that makes another technical challenge to neoadjuvant therapy for hilar cholangiocarcinoma. And then finally, the minority are resectable, as I told you, and really, even if they are, we have no room for growth. Now, if you look at all the therapies that we've been talking about and we want to apply them to the neoadjuvant setting, if you look at the actual radiographic response, it's not that great. That's the reality. It's somewhere in the 30% range, maybe, if you're seeing actual radiographic response. In the hilar cholangiocarcinoma situation, sometimes these tumors, if they grow by 2 millimeters, we've actually gone from resectable to not resectable. And that's what we're dealing with, millimeters here. And again, patients want surgery. You're dealing with something that we think is resectable, and if you enroll someone in a neoadjuvant trial and it grows 2 millimeters, and after that you tell them it's not resectable, that's a very difficult situation. So I think we still have a lot of thinking to do in terms of how we're going to do at least therapeutic trials in terms of hilar. Now for intrahepatic cholangiocarcinoma, and this is what I'll focus on the rest on, with resection as upfront therapy, again, the 5-year overall survivals range in the 30 to 35% range, and this is a multinational group that Tim Pollack leads. So if we start applying the standard of care and this is kind of the theme I would like to kind of touch upon as we end, the metastatic standard of care right now in terms of cytotoxic chemotherapy applying to all patients would be GemCis. And again, this was spearheaded by the UK group by Dr. Valle, who's sitting over there, and Bridgewater, who you just heard. Now, you see the 11.7-month median survival, and now Dr. Schroff and the group at Anderson and Mayo have had some phase 2 data. So, well, if 2 drugs is good, GemCis, let's add nab-paclitaxel, see what it does. You have PFS improves to 11.4 months, and the median OS in that single-arm phase 2 is 19.2 months. And this kind of data has led to this randomized trial, which is going to be the first randomized trial in the U.S. for biliary malignancies, looking at that triple drug regimen compared to the current standard of care. Now, what really happens in terms of surgical trials and neoadjuvant trials is we wait for these trials to be done in the metastatic setting. This is what's happened in pancreas cancer with FOLFIRINOX and gemabraxine. So in an effort to prevent this, let's wait 4 years for this trial to accrue, 3 to 5 years of follow-up, 1 year to be published. It's almost a decade by the time we get the results of this trial that Dr. Schroff is leading. Our efforts in the surgical working group and this and other friends around the country, we're really saying, let's try to decrease that lag of extrapolation of data to patients with resectable disease. And let's try to get these trials done concurrently for patients with resectable disease. So this kind of brought together this study hypothesis that we can actually deliver GemCis and nab-paclitaxel in a feasible way to patients with resectable intrahepatic cholangiocarcinoma. And again, we focused on intrahepatic cholangiocarcinoma for the reasons I just delineated to you for hilar and distal. And the point of this is, again, a feasibility study, just in thinking that we can get through it and making sure that patients can actually get to resection. And we're looking at the secondary objectives of resectability rates, recurrence-free survival, and overall survival. And of course, we'll capture blood and tissue for correlative studies later. So who are the patients we're targeting for this? Again, this is all about a relationship between a surgeon and the physicians and the patient. And you can't just say, well, any small little cholangiocarcinoma, we're going to give you preoperative therapy, like a 2-centimeter lesion. That would be a tough sell, I think. But I think we all have equipoise and believe and are true of our hearts that there are these high-risk, technically resectable, but oncologically high-risk tumors. And these are tumors that we defined as greater than 5 centimeters, T-stage greater than 1B, multifocal tumors. So you have that one tumor, but then it has a couple little satellites or moons around it, presence of major vascular invasion, or the lymph nodes are enlarged or involved on a PET scan or even a biopsy. These are patients that have tumors that we can, yes, technically remove, but we know oncologically they're very high risk for early recurrence. So that is pretty much the inclusion criteria from a thing. Otherwise, it's all the standard things from a trial standpoint in terms of comorbidities and baseline function. And then again, the trial is basically giving the triplet drug regimen. This is a single-arm study, but for 4 cycles or 3 months prior to resection, and then going on resection. And then after that would be standard of care, which today would be adjuvant capecitabine per the BILCAP trial. And again, I mentioned we do have correlative studies planned in terms of looking at blood and tissue. We'll have pre-op biopsies as well compared to the specimen and the resection. We're planning to enroll 34 patients. This is a safety and tolerability study primarily, as I told you. And really, this is kind of ending on the importance of collaboration. This is, again, through the collaboration of this group here and through the ICRN. But this study basically is enrolling at Virginia Mason, Mayo, MD Anderson, and Emory. We are open at Emory. We should be open at Virginia Mason tomorrow, and Mayo Clinic and MD Anderson are very close. But again, we're all working together. We already have 2 patients on at Emory, and the first patient's already gone through it, gone through the regimen and awaiting surgery. So where are we going from here? I think, the surgery working group that's assembled here, Christina Ferroni was I think the first surgeon, and Mike Chody and Christina Ferroni were the first surgeons really to be involved. Flavio has been invited me to attend this 3 years ago, and I think it was just an amazing experience. We have a very dedicated group working toward these issues that I delineated and working toward other trials. The gold standard would be therapeutic trials. We're doing this trial of Gemcis nab-paclitaxel, and if we have if it works, it's feasible, we see a response, this is something that we hope to turn into a randomized phase 2 trial, but they're challenging for the reasons that I dictated below. So what are the other options besides therapeutic trials? Well, there are other options in terms of proof of concept. What about, just testing other drugs, not as in therapeutic intent, but maybe just giving 1 dose or 2 doses of a drug. The difference is then we have the specimen when it comes out, and you can actually look at the response. What's the change in the T cell milieu? What is happening? Can we identify other targets? You heard about circulating tumor cells. Can we get pre and post blood? It's already being done at MGH, looking at, how can you pick the patients who are going to recur and select them for a good adjuvant therapy? But this is how we can really identify other targets and really kind of broaden this idea of neoadjuvant trials. It doesn't necessarily have to be a therapeutic trial, but could improve patient selection and lead to other therapeutic strategies. So with that, again, I emphasize this cannot be done without the collaboration and cooperation of all people here, and importantly, the Cholangiocarcinoma Foundation, which really is the glue that brings this group together. With that, thank you very much. Appreciate it.
All right, thank you. Thank you, Shishir. This was great. We get it again. Okay, on the webcast.